I want to give you a number that I think most people find genuinely surprising when they first hear it. Approximately 1 billion people worldwide have vitamin D deficiency. Not insufficiency, frank deficiency, defined as a blood level below 25 nanomoles per liter. A further billion have insufficiency, defined as levels between 25 and 50 nanomoles per liter. Put those two together and you have approximately 2 billion people, roughly 1/4 of the entire global population, with vitamin D levels low enough to be affecting their health in measurable and documented ways. In some regions and populations, the prevalence is considerably higher. In South Asian communities in Northern Europe, deficiency rates approach 70 to 80% in winter months. In adults over 65 globally, the majority are deficient. Vitamin D is simultaneously one of the most discussed and most misunderstood nutrients in medicine. On one side, a wave of observational research linking low vitamin D to virtually every chronic disease imaginable. Heart disease, cancer, diabetes, depression, autoimmune conditions, dementia, and beyond, leading some commentators to claim that vitamin D supplementation will solve modern medicine's biggest problems. On the other side, randomized controlled trials that have been more modest in their findings, leading some clinicians to dismiss vitamin D as overblown and the supplementation industry as opportunistic. The truth, as is almost always the case in medicine, lies somewhere between these two positions and requires a careful reading of what the evidence actually shows and what it does not. After reviewing the evidence extensively, my clinical position is this. Vitamin D deficiency is a genuine and widespread problem with real health consequences, particularly for bone health, immune function, muscle function, and metabolic health. The evidence for supplementation correcting these consequences when deficiency is the cause is strong. The evidence for supplementation producing additional benefits in people who are already sufficient is much weaker. The difference between these two statements is the distinction that most vitamin D discussions miss, and it is the distinction that determines whether vitamin D supplementation is a clinical necessity or a waste of money for any given individual. In this video, I will explain what vitamin D actually is and why your body needs it, how deficiency develops and who is most at risk, the 8 warning signs that suggest your levels may be low, what the evidence actually shows about the health consequences of deficiency, including the areas where the evidence is strong and the areas where it is less clear, and the evidence-based approach to testing, supplementing, and monitoring. Let us get into it. The first thing to understand about vitamin D is that it is not technically a vitamin at all. Vitamins are defined as organic compounds that the body cannot produce and must obtain from food. Vitamin D does not fit that definition. When the skin is exposed to UVB radiation from sunlight, a precursor molecule, 7-dehydrocholesterol, is converted to cholecalciferol, or vitamin D3. This is then processed in the liver to form 25-hydroxyvitamin D, the form measured in blood tests, and further activated in the kidneys and other tissues to produce 1,25-dihydroxyvitamin D3, also known as calcitriol, which is the biologically active form. This makes vitamin D a hormone, a signaling molecule produced in one tissue and acting on others, rather than a dietary micronutrient in the conventional sense. The biological significance of this distinction is enormous. Vitamin D receptors, VDRs, are found in virtually every tissue and cell type in the human body. This is not what you would expect from a nutrient involved only in calcium regulation. VDRs are present in immune cells, brain cells, cardiac muscle cells, pancreatic beta cells, skeletal muscle cells, skin cells, and cells lining the gut and respiratory tract. This distribution tells us that vitamin D is involved in the regulation of far more than calcium homeostasis. It is a systemic hormonal signal with roles in gene expression, immune modulation, cell proliferation, and inflammatory regulation across virtually every organ system. The functions of vitamin D that are most clearly established by clinical evidence are calcium and phosphate absorption from the gut and calcium reabsorption in the kidneys, the mechanism by which vitamin D maintains bone mineralization, modulation of the innate and adaptive immune system, including the activation of antimicrobial peptides in macrophages and the regulation of T-cell function, regulation of cell growth and differentiation, the mechanism implicated in the cancer risk associations, and insulin secretion from pancreatic beta cells, the connection to metabolic syndrome and diabetes that I will return to later. Vitamin D reaches adequate levels through three routes: sunlight, the primary source for most humans historically; diet, oily fish, egg yolks, fortified dairy, and mushrooms exposed to UV light contain modest amounts; and supplementation. The challenge of modern life is that most adults in temperate latitudes cannot produce sufficient vitamin D from sunlight for 6 or more months of the year. Work patterns and indoor lifestyles reduce sunlight exposure even in summer months. Sunscreen use, entirely appropriate for skin cancer prevention, blocks the UVB radiation required for vitamin D synthesis. And food sources, with the exception of oily fish, contain far less vitamin D than is required to achieve optimal levels. The result is widespread deficiency that no amount of dietary modification alone can reliably address. The most powerful determinant of vitamin D status is latitude. Above approximately 35 degrees north or south, the angle of the sun for much of the year means that UVB radiation does not reach ground level in sufficient intensity to drive significant vitamin D synthesis in skin. The United Kingdom, most of Europe, Canada, and the northern United States all fall within this zone. In the UK, for example, meaningful vitamin D synthesis from sunlight is only possible between April and September, and even within those months requires exposed skin and direct midday sunlight. For the rest of the year, dietary and supplemental sources are the only viable options. Melanin, the pigment that determines skin tone, absorbs UVB radiation and reduces the rate of vitamin D synthesis. Darker skin, which evolved as protection against intense sunlight at lower latitudes, requires significantly more sun exposure to produce the same amount of vitamin D as lighter skin. In northern European latitudes, individuals with darker skin tones are at substantially higher risk of deficiency. Studies in the UK consistently show vitamin D deficiency rates of 70 to 80% in South Asian, African Caribbean, and Black African communities during winter months, a clinically significant public health finding that remains inadequately addressed. Other high-risk groups include adults over 65, because skin produces vitamin D less efficiently with age and outdoor activity is often reduced; people who are obese, because vitamin D is fat-soluble and is sequestered in adipose tissue, reducing its bioavailability; people with conditions causing fat malabsorption, Crohn's disease, celiac disease, cystic fibrosis; people taking certain medications, including some anticonvulsants, glucocorticoids, and antiretrovirals; exclusively breastfed infants, because breast milk is low in vitamin D; and people who cover their skin for religious or cultural reasons, or who spend the majority of time indoors. These are the signs most commonly associated with vitamin D deficiency in clinical practice. Most are nonspecific; they have many possible causes, but in the context of the risk factors I have just described, they should prompt a vitamin D blood test rather than attribution to other causes by default. Vitamin D is essential for calcium absorption and bone mineralization. In severe deficiency, inadequate mineralization of the bone matrix produces osteomalacia in adults, a condition characterized by diffuse, deep bone pain, typically worst in the lower back, hips, pelvis, and legs, and associated with bony tenderness on direct pressure. Osteomalacia is the adult equivalent of rickets, the childhood bone disease that re-emerged as a clinical problem in several countries following the recognition of widespread vitamin D deficiency in children. Milder degrees of deficiency produce a subtler, more diffuse musculoskeletal aching that is frequently misattributed to fibromyalgia, arthritis, or simply getting older. Vitamin D receptors are present in skeletal muscle cells and play a direct role in muscle protein synthesis, calcium handling within muscle, and fast-twitch muscle fiber function. Vitamin D deficiency causes a proximal myopathy, weakness that is most pronounced in the proximal muscle groups of the thighs and upper arms. This presents clinically as difficulty rising from a chair, climbing stairs, or lifting objects above shoulder height. In older adults, this proximal weakness is a significant contributor to falls and fractures, and multiple trials have demonstrated that vitamin D supplementation in deficient older adults reduces fall risk measurably. Fatigue is one of the most commonly reported symptoms of vitamin D deficiency, and one of the most commonly dismissed by clinicians because it is so nonspecific. The mechanism is not fully understood, but likely involves vitamin D's role in mitochondrial function, the cellular energy production machinery, and its effects on thyroid hormone metabolism. Multiple observational studies have found correlations between low vitamin D levels and fatigue scores, and a subset of randomized trials have demonstrated improvement in fatigue following correction of deficiency. In a person with unexplained fatigue who has not had their vitamin D checked, particularly in the high-risk groups I described, measurement and correction of deficiency is a simple, low-risk intervention worth pursuing before more invasive investigations. Vitamin D plays a central role in innate immune function. It activates the expression of antimicrobial peptides, cathelicidin and defensins, in macrophages and epithelial cells lining the respiratory tract. These peptides are the body's first line of defense against respiratory pathogens. In vitamin D deficiency, this defense is impaired. A Cochrane-level meta-analysis of 25 randomized controlled trials covering over 11,000 participants confirmed that vitamin D supplementation reduces the risk of acute respiratory infections, particularly in people who are deficient, with the strongest effects seen in people receiving daily or weekly doses rather than large, infrequent boluses. People who suffer from recurrent upper respiratory infections, particularly in winter months, should have their vitamin D level checked. Vitamin D receptors are expressed throughout the brain, including in regions involved in mood regulation, the prefrontal cortex, hippocampus, and limbic system. Vitamin D influences the synthesis of serotonin and dopamine and modulates the hypothalamic pituitary adrenal axis. Multiple large observational studies have found associations between low vitamin D levels and depression, and the seasonality of vitamin D deficiency, lowest in winter, maps onto the well-documented seasonality of depressive episodes. Randomized controlled trial evidence for supplementation improving mood is mixed. Stronger in trials that specifically selected deficient participants than in general population trials. This pattern supports the hypothesis that correction of deficiency restores function, rather than supplementation producing additional benefit in the sufficient. Vitamin D plays a role in all phases of wound healing, from the initial inflammatory response through to tissue remodeling. It regulates the production of growth factors required for angiogenesis, new blood vessel formation, and modulates the immune response at the wound site. People with vitamin D deficiency have been shown in multiple studies to have slower wound healing after surgery, higher rates of post-operative infection, and impaired healing of diabetic foot ulcers. In the context of the diabetic neuropathy and wound healing problems covered in video 4, checking and correcting vitamin D deficiency is a specific and underutilized clinical intervention. Vitamin D receptors in hair follicles are involved in the cycling of follicles between their growth and resting phases. Deficiency of vitamin D has been associated with alopecia areata, patchy hair loss, and with diffuse telogen effluvium, generalized hair shedding. The association is strongest for alopecia areata, where vitamin D levels are consistently lower in affected individuals compared with controls in multiple studies. Hair loss is multifactorial, and vitamin D deficiency is not the only or most common cause. But in someone presenting with unexplained hair loss who has not had their vitamin D checked, it is a simple and low-cost investigation to add to the workup. This is the connection I most want to emphasize given its relevance to the broader series. Vitamin D receptors are expressed in pancreatic beta cells, the cells that produce insulin, and vitamin D directly regulates insulin secretion and sensitivity. Vitamin D deficiency impairs beta cell function and promotes peripheral insulin resistance through inflammatory mechanisms. Elevated inflammatory cytokines in the deficient state directly interfere with insulin signaling pathways. Multiple large observational studies confirm an inverse relationship between vitamin D levels and risk of type 2 diabetes. Randomized trials in vitamin D deficient pre-diabetic individuals have shown that high-dose supplementation significantly reduces the risk of progression to overt diabetes. In the context of metabolic syndrome, covered in video 11, checking and correcting vitamin D deficiency is a specific and evidence-supported component of metabolic management. The areas where the evidence for vitamin D's role is strongest are bone health. The relationship between vitamin D, calcium absorption, and bone mineralization is established beyond reasonable doubt, and supplementation reduces fracture risk in deficient elderly populations. Fall prevention. Multiple trials confirm that vitamin D supplementation in deficient older adults reduces fall risk, the primary cause of hip fracture. Immune function. The Cochrane meta-analysis confirmed respiratory infection reduction and muscle function. Proxy evidence from the fall prevention trials and specific muscle biopsy studies confirm vitamin D's role in muscle protein synthesis and fiber type composition. Areas with moderate evidence, where observational data is strong but randomized trial evidence is more nuanced. Diabetes and metabolic health. Large trials including D-Health and VITA show significant risk reduction in pre-diabetic deficient populations. Cardiovascular outcomes. The VITAL trial showed significant reductions in cardiovascular mortality in a subgroup analysis of people not taking aspirin. Immune modulation. Beyond acute infections, growing evidence for vitamin D's role in autoimmune disease prevention and management, particularly in multiple sclerosis, rheumatoid arthritis, and inflammatory bowel disease, areas where the evidence is weaker or more contested. Cancer prevention. The VITAL trial showed a significant reduction in cancer mortality, but not cancer incidence, suggesting vitamin D may influence tumor progression rather than initiation. Depression. Mixed trial evidence, strongest in deficient populations. All-cause mortality. Meta-analyses show modest reductions that may reflect correction of frailty and immune dysfunction rather than direct effects. The important caveat for all of these categories is that trial populations have often included participants who are not frankly deficient, which dilutes any genuine effect of deficiency correction. The principle that treating deficiency restores function, while supplementing sufficiency provides little additional benefit, explains much of the inconsistency in the literature. The optimal vitamin D level and the dose required to achieve it are genuinely debated. Most guidelines define sufficiency as above 50 nanomoles per liter of 25-hydroxyvitamin D. Some experts argue for a higher threshold of 75 to 100 nanomoles per liter for optimal immune and metabolic function. The standard supplementation recommendation in many countries, 400 IU daily, is widely acknowledged as inadequate for restoring deficient levels in most adults. Most clinical evidence for meaningful health benefits comes from trials using 1,000 to 4,000 IU daily or equivalent weekly doses. Toxicity from excessive supplementation is rare but real at sustained doses above 10,000 IU daily without medical supervision. Vitamin D status is assessed by measuring serum 25-hydroxyvitamin D, 25-OHD, from a standard blood test. This is the storage form of vitamin D and reflects both cutaneous synthesis and dietary and supplemental intake over the preceding weeks to months. It is the clinically relevant measurement for assessing adequacy. The active form, 1.25-dihydroxyvitamin D, is tightly regulated and is not a useful measure of vitamin D status in most clinical contexts. Reference ranges vary by laboratory and guideline, but the most widely used clinical thresholds are below 25 nanomoles per liter, deficiency, associated with osteomalacia and significant immune and metabolic impairment. 25 to 50 nanomoles per liter, insufficiency, associated with suboptimal bone, immune, and metabolic function. 50 to 75 nanomoles per liter, adequate for most people. Above 75 nanomoles per liter, optimal by more conservative guidelines. Above 250 nanomoles per liter, potential toxicity risk, though true toxicity from oral supplementation typically requires sustained levels above 375 nanomoles per liter. Testing is clinically indicated in all high-risk groups I described: darker skin tone in temperate latitudes, age over 65, obesity, conditions causing fat malabsorption, indoor lifestyles, and those covering skin. In the absence of high-risk features, empirical supplementation at 1,000 to 2,000 IU daily is reasonable and safe without testing. Testing is particularly valuable when symptoms suggest deficiency, when higher dose supplementation is planned, or when monitoring response to supplementation in known deficiency. These 8 actions are ordered by evidence strength and practical priority. The protocol differs depending on whether you are deficient, insufficient, or apparently sufficient, a distinction that matters more for vitamin D than for almost any other supplemented nutrient. If you have any of the risk factors I described, darker skin tone in a temperate latitude, age over 65, obesity, fat malabsorption condition, predominantly indoor lifestyle, covering skin, the single most important action is to know your level. A 25-OHD test costs very little on a standard blood panel and informs whether you need aggressive repletion, moderate supplementation, or simply maintenance. The different treatment strategies for deficiency, insufficiency, and maintenance are distinct enough that measuring first is worth doing. For adults who are not at high risk and have not had their vitamin D tested, which describes the majority of adults in temperate latitudes, a baseline daily supplement of 1,000 to 2,000 IU of vitamin D3 is safe, inexpensive, and the most clinically justified public health recommendation. The government recommendation of 400 IU daily was set primarily to prevent rickets and osteomalacia in children and does not reflect the dose required to achieve adequate levels in most adults. Multiple systematic reviews confirm that 1,000 to 2,000 IU daily is sufficient to maintain adequate levels in most people who are not severely deficient to begin with. In frank deficiency, levels below 25 nanomoles per liter, a loading strategy is required. Many guidelines recommend a loading course of 50,000 IU once weekly for 6 to 8 weeks, followed by a maintenance dose. In practice, many clinicians use 3,000 to 4,000 IU daily for 3 months as a well-tolerated alternative that is easier to adhere to. Retest after 3 months of supplementation in known deficiency to confirm adequate response and adjust the maintenance dose accordingly. Higher doses than 4,000 IU daily should generally be supervised by a healthcare professional, particularly in people with conditions affecting vitamin D metabolism. Vitamin D supplements come in 2 forms: D2, ergocalciferol, derived from plant sources, and D3, cholecalciferol, derived from animal sources or lichen. Multiple head-to-head trials confirm that vitamin D3 is approximately 87% more potent than D2 at raising and maintaining serum 25-OHD levels. Vitamin D3 should be the default choice. Most supplements sold as vitamin D are D3, but it is worth checking the label, particularly with vegan or vegetarian products, which may default to D2. Vitamin D is a fat-soluble vitamin. Its absorption from the gut depends on the presence of dietary fat to stimulate bile release and micelle formation. Taking vitamin D with a meal that contains a source of fat, olive oil, nuts, eggs, dairy, increases absorption by approximately 50% compared with taking it on an empty stomach. This simple change significantly improves the effectiveness of a given dose without requiring any increase in the supplement itself. Magnesium is a cofactor for the enzyme that converts the storage form of vitamin D, 25-OHD, to the active form, 1.25-OH2D, in the kidneys. Magnesium deficiency, which is common in adults eating a low-vegetable Western diet, can impair vitamin D activation and reduce the clinical effectiveness of supplementation. Adequate magnesium intake. Approximately 400 milligrams daily for men and 310 milligrams for women should accompany any vitamin D supplementation strategy. Dietary sources of magnesium include dark leafy greens, legumes, nuts, seeds, and whole grains. If dietary intake is inadequate, magnesium glycinate or citrate supplements are well-absorbed options. Sensible sun exposure, defined as exposing arms and legs to midday sun without sunscreen for 15 to 30 minutes on days when UV index is 3 or above, produces significant vitamin D synthesis and is entirely compatible with a balanced approach to sun safety. Daily sun exposure of this duration in summer months is sufficient to produce approximately 10,000 to 20,000 IU of vitamin D3, far more than any oral supplement. The vitamin D synthesis pathway is self-limiting. Excess pre-vitamin D is converted to inactive compounds rather than to toxic levels. The public health challenge is that for much of the year and much of the world, this UV index is simply not achievable. Supplementation is therefore not an alternative to sunlight, but a practical necessity for the months when sunlight is insufficient. When taking vitamin D at doses above 2,000 IU daily, there is a theoretical and increasingly evidence-supported rationale for co-supplementing with vitamin K2, specifically the MK7 form, found in fermented foods and available as a supplement. Vitamin D increases calcium absorption and circulating calcium levels. Vitamin K2 activates osteocalcin and matrix GLAA protein, proteins that direct calcium into bone and prevent its deposition in arterial walls. This is particularly relevant in people with cardiovascular disease or those at higher risk of arterial calcification. A combination of vitamin D3 and vitamin K2 MK7 at doses of 100 to 200 micrograms daily is a reasonable evidence-based combination for adults supplementing above 2,000 IU of vitamin D. I want to leave you with the clear evidence-based position that I started with. Vitamin D deficiency is real, widespread, and consequential for bone health, immune function, muscle function, and metabolic health. Correcting deficiency with appropriate supplementation restores these functions and reduces measurable clinical risks for falls, fractures, respiratory infections, and diabetes progression in deficient populations. Supplementing beyond sufficiency provides limited additional benefit for most people. The practical takeaway is simple. Know your level if you are at risk. Supplement intelligently if you are deficient or at risk of becoming so, and do not spend money on high-dose vitamin D if your levels are already adequate. Vitamin D deficiency sits at the intersection of immune health, bone health, and the metabolic syndrome cluster we covered in videos 4, 8, 10, and 11. It is one more modifiable factor in the constellation of things that determine whether your health trajectory over the next 20 years is one of gradual decline or of sustained vitality. The interventions in this series collectively represent the most evidence-based approach to preventive health that I know of. Apply them with consistency, not perfection, and the compounding benefits over a decade are transformative. If this video was useful, share it, particularly with someone who is older, darker-skinned in a northern latitude, or who spends most of their time indoors. They are the people most likely to be significantly deficient and least likely to know it. Subscribe so you do not miss the next video, where I will be covering thyroid disease, why it is the most commonly missed diagnosis in modern medicine, why the standard TSH test frequently gives false reassurance, and what the full thyroid picture actually looks like. I will see you there.